Hi, I'm Joan Beasley, and I'm here to present the overview of the START model. I just want to remind you that this is an overview, and it doesn't really go into great detail about any of the elements of START. START is a pretty complicated program in some ways, but really it's very elegant in terms of the way we developed it over the last 30 years in order to meet the needs of individuals with intellectual and developmental disabilities and mental health needs. I'm Joni Beasley. I'm the director of the National Center for START Services at the Institute on Disability at the University of New Hampshire. I just want to let you know, it's really funny that the first slide is, let's review what we've learned. I think in every conversation, every discussion, everything that we do with START, it's the first thing that you have to think about is what have I learned and what am I learning from the process, from the people, from the families, from the systems that we support. And I like to quote people who are much smarter and well-known than I am so that perhaps you'll listen. And the first quote is, "The measure of our intelligence is the ability to change." So it isn't just about what you learn, but what you do about it, how you act upon what you learn, how open you are to learning. And it's a big part of the model and a big part of our process. One of the things that we've learned is that across the United States, a lot of people have been diagnosed with intellectual and developmental disabilities. And when I talk about that, I'm talking about a disability that involves impairments and general abilities that impact the person's adaptive functioning, as defined in the DSM-5. The DSM-5 refers to intellectual disabilities as an impairment, and that is something that is a little bit different from a disability. It is something that needs treatment and support in order for the person to flourish, but it doesn't mean that it limits their ability to flourish through giving up on them or thinking that they don't have potential, but actually meeting their potential through those supports. Epidemiological studies have established that the incidence and prevalence of mental health conditions in this population is typically 2 to 3 times greater than the general population. And oddly enough, we just had a training this morning, a clinical education team training, which you'll learn a little bit about in this presentation, and later on if you develop a START program or are part of a START program, where we really talked about why that's so. And there's a combination of factors, all of which we try to address through START, having to do with a person's vulnerabilities due to the different structural brain issues, but also their life experiences, the ecology in which people grow up, the lack of inclusion of people with intellectual disabilities and autism all create an opportunity for somebody to become perhaps more anxious and depressed than they ordinarily would if all other conditions held stable. So not only are people with IDD more vulnerable to developing mental health conditions, but the life experiences that they have create opportunities for those conditions to develop as well. And many mental health conditions often contribute to challenging behavior. And again, this morning we were just talking about executive functioning and challenging behavior, the ability to take in demands and stimulus in your environment and respond to it, whether it's internal, external, or situational. And sometimes we see that people with IDD express those challenges through behavior that is not considered acceptable, aggression and self-injurious behavior. And so when we get referrals, most of the people for START and mental health services are due to these challenges of aggression and self-injurious behavior. There are lots of barriers in the IDD system. And one of the things that I hope to remind us all of is I am not a person with IDD. I am not somebody who is receiving services. And as a result, I'm always speaking from the outside looking in terms of understanding these barriers and how they actually affect people. So I'm very respectful of the fact that the story is really their story. I'm telling somebody's story through a third party rather than telling the story of myself. But I have been doing this work for a very long time, and I have a sister with intellectual disabilities, so I'm very close to people who have these stories and face these challenges. And some of them include how troublesome behaviors or people just not doing what is expected of them in extreme, what would be considered more extreme ways, is considered unacceptable in many support and service venues on the DD side. And as a result, the last and least served in the community are people who have mental health conditions in IDD. These are the people where there's still a tendency to think that individuals need more restriction and more segregation in society than maybe other people with IDD. There's been some social movement toward including people with autism and ID into society, but those who have mental health issues and IDD have not really been included in this movement. There's a continued concept of primary versus secondary, and that this is really a dual diagnosis. These are all kind of fallacies. People really are complex beings. There are many things about me that make up who I am, from my history to my various diagnoses, to the fact that I wear bifocal lenses, to whether my feet hurt, how tall I am, my life experiences, my culture, my economic background, my education. There's no two things that would define me, and there's no two things that define these individuals. And so one of the things that happens, however, is because we try to fit people into systems, we really think that their challenging behavior can be fixed by one system or the other, that the IDD system can do something, a behavior plan or some kind of a control strategy to get that person to behave properly, or there's a magic pill or plan on the MH side that if only people had access to it, they can be fixed. And I'm here to say that, as I said earlier, since we as a society have created this phenomenon, we as a society have to change the way we view people who have these challenges. There are many barriers in the mental health system as well, and I spoke to them a little bit in the last slide. But really, the most important thing to get out of this slide is that people do not get access to mental health services who have IDD early on in the process of needing them. Most of the time, people get access through the emergency room, and it's very stigmatizing. There's very poor education on the mental health side to actually treat individuals with mental health conditions who have IDD, and a lack of understanding. Not so long ago, we really thought that if you didn't have a higher enough IQ, you couldn't actually experience depression. And now most of us believe that that is an absurd thought, but it is not something that some people disbelieve. There are many who still believe that in order to have a mental health condition, you have to have a certain IQ score. And again, there's this whole thing about primary versus secondary diagnoses, which is supposed to help us target services and treatment, which is not really very helpful and has gotten in the way of people getting access to the right care on the mental health side. It's not about dual diagnosis. It's about understanding the person's presentation from a biopsychosocial perspective. And Engel developed this model, this biopsychosocial model, back in 1977. And really, it's a general model or approach that states that biological, psychological, and social, environmental experiences play a significant role in functioning in the context of disease or illness. If you take, for example, heart disease, you don't just give somebody treatment for their cardiac condition, medication, surgery, et cetera. There's a whole lifestyle change that's needed in terms of diet and exercise in order to maintain a healthy heart. You would never say that it's either biological or psychological or social. There's a whole construct to it that has to be understood in order to promote health. And health is best understood in the context of all three of those elements. If used in mental health, we really turn to humanistic psychology, family systems, positive psychology, and other more strength-based practices to really see how we can integrate a biopsychosocial approach. Dr. Bill Gardner actually applied this approach to understanding challenge and behavior in individuals with IDD back in the early 2000s. And one of the articles that we have, and one of the presentations that we have, is Dr. Gardner explaining and examining the role of biopsychosocial in challenging behavior. So here's another portrayal of the approach, and as you can see, they all intersect to promote mental health. They also all intersect to undermine mental health. So what we are trying to do at START is to give people mechanisms to promote emotional well-being and mental wellness, and these factors have to be integrated in order to contribute to that stability and flourishing of individuals. It's not just enough to treat an illness. What you really want is the promotion of your well-being. Imagine coming home from work or school or reporting back to a family member about how your day went and just reporting that you didn't have constipation that day. It seems kind of ridiculous to actually talk about how a good bowel movement makes a great day, but it does. But the other thing that's true is in the context of that, there are other opportunities that arise, psychological and social opportunities that free you up when you're feeling better and you're not in GI distress, and how GI distress can undermine your ability to benefit from psychosocial opportunities. This is the same that's true for everyone. It's true for people with ASD and IDD. I was telling somebody recently that I think my entire mission, my entire career, I began this work in 1976, and I really don't know how many years ago. I think that's like 42 years ago. I was young, though, so don't get too excited. But my entire mission in life has been to just try to convince people that people with disabilities are human, and they benefit from the same human capacity, the same human opportunities, and they are challenged by the same challenges as other humans. And so if you try to really look at people's humanity, you're going to go a long way. So we developed the START model in 1988, and the model is very different from the original one, although there was a foundation of really looking at linkages as a foundation for getting systems to work together, being very family-focused and supporting the functional opportunities of families, and also being very strength-based and seeing what is really good about the person, what is good in them, what gives them strength and purpose so that they can flourish. And the other thing that was really important to our mission was a rigorous understanding of all of the challenges that they face from a diagnostic perspective. So as we worked with Dr. Robert Sovner in this, we really did not feel like you couldn't be too rigorously clinical and that would lose being person-centered. I actually, at one point, I had invited this very wonderful physician who was very big on person-centeredness to come and talk to us at START when Dr. Sovner was still there. And she said, "Oh, Robert Sovner, he's too clinical. I'm person-centered, he's clinical." Well, I'll tell you something. My sister is now in treatment for cancer. She actually just finished her chemotherapy yesterday. And I have to tell you, she needed clinical support, and she also needed a person-centered and continues to need a person-centered understanding. Being nice to her and not giving her chemotherapy would not have helped her with her cancer. Giving her chemotherapy but not providing support to her about how she faces the challenges of her cancer would not have helped her very well with her cancer either. So it isn't about one or the other, it's both. Herb Lovett used to call it 2 mints in one. There was an old Certs commercial. I won't go into it. Most of you people who are watching this are too young. So START, the idea is that partnerships enrich the system. We are nationally recognized for quite a while now, and I'm going to discuss our values next so you can see kind of what we're thinking in this practice. We really believe that capacity building begins with positive engagement, and the positive engagement has to start with the person being referred. A lot of people are referred with terrible reputations, and the first thing we do is we debunk those and look at the person's strength of character, their courage in working with us, and their ability to change in positive ways to promote their own well-being and for us to engage with them in that process. We also, capacity has to be part of systems change. Any system or service does better when they collaborate with others. So it's a big part of our mission and has been since 1988. Service recipients and their families are our most valued partners. A self-advocate recently reminded me that a self-advocate or a service recipient does not have the same perspective as a family member. We value both, and we have to really make sure that we both have the individual's input and the family's input, and that we don't see them as one and the same. While families can speak for the interests of their loved ones, they don't really represent who that person is. That person stands for themselves, and it's very important that you don't ignore that individual and just have the family talk about it. On the other hand, the natural supports and people who love the person are part of the dialogue and discussion and really need to be valued and supported in their journey as well. So help begins with providing oxygen. So we do a lot of work in crisis intervention, and nobody, and I've had this discussion several times with people, nobody gets referred to START because something's going well. It's usually something hasn't gone well. And so the first thing you need to do is you need to kind of shore up the system, the person and the system, so that you can take a closer look at what's going on. And I describe that as providing oxygen. A lot of the phrasing that I use and demonstrations that I have come from personal experiences. So I'll share this one with you. Several years ago, my mother was sitting at the dining room table after a hard-won game of Scrabble. Oh, by the way, when my mother and I played Scrabble, my mother had some dementia by the time she played Scrabble, but she was always very good at Scrabble. If I won, she attributed that to her being a good mother, and if she won, she attributed that to being herself. So she was always a winner at Scrabble. So anyway, one day we were sitting at the dining room table, and my mother had terrible pain in her neck and her shoulder. And so we called an ambulance. I gave her an aspirin. I just did that because you're supposed to do that. I actually didn't even know that she was having a heart attack. For some reason, I had been trained in this, but I forgot about something called the carotid artery, which is where she felt the pain. And it felt like it took years for the ambulance to come. It took about 4 minutes, but each minute, when you're in crisis, each minute, each hour seems like an eternity. The ambulance came, and they didn't hesitate because she couldn't breathe to give her oxygen. As soon as they gave her oxygen, it was like an emotional oxygen for everybody else in the room. She became more comfortable, help was there, and we were able to move on with trying to figure out what was going on, move her to the hospital, and proceed in doing the things that we needed to do. It started with the oxygen. And it really reminds me that people in distress need everything to calm down, and then they need hope that things will get better. And that's what we see as oxygen, is to try to stabilize the situation and provide some hope that things will get better. We also talk about what effective services are. Again, back in the day of developing START, one of the things that we didn't have access to in Northeast Massachusetts was hospitals for people with ID who had mental health conditions. So we would try our best by advocating as much as we could to get people hospitalized when they had an acute mental health condition. So they got access, but the services weren't that good because they didn't know how to serve people with ID. So it really wasn't all that appropriate. And what we learned was access alone doesn't guarantee that services are going to be effective. So they have to be appropriate. And thirdly, they have to be accountable. So increases the depth of knowledge and capacity to provide services for all really relies on those three things. That you have to have access to appropriate services and some accountability with regard to the outcomes. In fact, that accountability is very much part of what we do with the START model. We're constantly evaluating what we do and for who we're doing and whether the benefits are what we think they're going to be to ensure that services are effective. We also have to be open to learning and teaching. And one of the biggest, I guess, as if you're a member of a START team, you'll probably get to know me and you'll realize that I am going to give you feedback that might not feel good at times, because the feedback has to do with teaching new ideas and the rigor that we at START apply. I'll try to make everything feel good, but if you're open to learning, then you will see it as what it's being offered to you. We have educational communities and forums and all kinds of trainings. Beth Grasso, as you know, is our director of training, to make sure that you have the opportunity to learn. And what we ask you to do when you learn is to teach others. This is a training for trainers. Everything we learn, we need to share. Every time we learn something new, we need to teach. And that way, what we're doing is building capacity. The idea is to really have people understand the population much, much better. And, you know, I often ask people if they know what diabetes is, or they know what a heart condition is, or if they know what cancer is, or they know what a seizure looks like, for example, or what to do when somebody has a seizure. Many, many people will say, yes, I know, yes, I know, yes, I know. And I'll ask them, do you have it or does a relative have it? And oftentimes they don't. But there's been a public education, a public awareness, a public dialogue in the community life situation where everybody kind of knows that diabetes has at least something to do with blood sugar. I don't think there's one person in society who's an adult who wouldn't know that. Or that when somebody says they have chest pains, you have to worry that they may be having a heart attack. Why? Because it's been in the public forum. It's been part of the public discussion. So we really think that the learning and teaching as part of the START model will help bring to the forefront people with autism, people with ID who have mental health conditions, so that there'd be a better understanding, so that people don't react in a way that is derogatory, condescending, and isolative, and that people will know what to do and who to get help from. That's very important. We are also very much a team approach, and this includes mutual respect that allows for teams to have input. We don't believe that there's one person who knows everything. In fact, we're sure there isn't one person who knows everything. We really promote teamwork, and if you're going to become a START coordinator, the first thing you'll learn is that you don't own a case or a family, that we share that responsibility, we work together as a team. We also value humanity and community. And so really what we're talking about here is remembering that the biggest asset that we have in our community, in our life, are our fellow human beings. And that people with intellectual developmental disabilities are just as much of an asset as anyone else. I think the biggest thing to undermine people's emotional well-being is for them to be born into having a diagnosis that somehow gives people the impression that these people have nothing to offer and nothing to contribute to their own lives and the lives of others. And this is absolutely untrue. And so we spend a lot of our time kind of reframing that, reteaching that, and learning about people so that we can share the common interests and goals and values with the people we serve and really support them in their journey. START is a model, which means that there are fidelity expectations, and we provide training and consultation to meet the fidelity to the model. We take this very seriously. When the model is followed appropriately, within the constraints of the model, we are able to see absolutely wonderful outcomes. That does not mean that the interpretation of the model doesn't apply to the local community and state in which it resides. There is adaptation within the context of fidelity, and if you decide to develop a START program, we can talk about that moving forward. So one of the essential ingredients of doing any of this work is to articulate why you do what you do. And one of the reasons that it's so important to articulate that is because you want to measure whether what you think you should be doing or what you think is going to happen is actually happening. And the public health model from the World Health Organization is an excellent portrayal of what a good public health system looks like, which includes primary, secondary, and tertiary services. Now, from a public health perspective, a lot of the primary interventions are what we would call preventative. So, for example, vaccines would be preventative to make sure that kids don't get measles or chickenpox. But in our case, because people come to START already having difficulty, we really see the primary, secondary, and tertiary interventions as crisis intervention strategies because the people come in crisis. And those primary interventions really create capacity so that they do not end up needing more specialized services or crisis services, but all three are provided through the START model. What you can see from looking at this example is that the potential impact of the model, of the intervention, increases with regard to the ability to support someone when you're at the primary level. So with the primary level, more people know what to do. There's a mutual understanding about how to address an issue, and there are many, many people who can benefit from it. When you're at the secondary level, fewer people know, and you need specialists to figure out what to do. Many people will benefit, but it's a specialty. It's more segregated. It's not part of the capacity of a system as a whole. You need special knowledge. When you get to tertiary, which is acute care services or emergency services, you're in the midst of a crisis and a terrible situation, most likely. There are fewer options. So if you go to the emergency room and you're very aggressive, you're going to end up with mechanical and chemical restraint 9 times out of 10, because the emergency room doesn't have the capacity to support you in any other way, which is why we really don't want people going to the emergency room. If you don't have secondary clinical support available to you and your primary interventions don't work, 9 times out of 10 you're going to end up calling the police for assistance, which is a tertiary intervention. They don't do therapy. They have handcuffs. That's what they do. It restricts the amount of intervention. In the START model, tertiary is considered facing the odds. We do have a mobile crisis team as part of the model that's 24 hours a day. And we do try to get involved on the secondary level before we end up in the emergency room where the police are called. But basically that is facing the odds. Secondary is beating the odds. And really, really primary is where we want to be. So anytime somebody is at the tertiary or secondary level, part of our job is to learn from that experience to push it up to the primary capacity building level. And really what we're talking about is a wellness-based model. Capacity to take care of yourself, capacity to deal with the challenges in life that inevitably we all face. This is a wellness-based model. And all of these factors that are listed here contribute to your wellness and your sense of health and well-being. And START incorporates all of these practices in how we assess an individual, how we work with the team, and how we work with the support system around the person to promote their well-being. And so, again, this is based on the World Health Organization that show that there are many, many circumstances and conditions that either undermine wellness when they're absent or promote well-being when they're present. And you'll notice that some of these, you can automatically see how people with intellectual disabilities and autism are sometimes excluded from these opportunities. So more people with ID and ASD are more likely to live in poverty than people who do not have cognitive impairment. So having an intellectual disability undermines your ability to graduate from high school, undermines your ability to get a job, undermines your ability to have the financial foundation to promote your own well-being. This is not because they're not capable of it, it's because it's expected that you are not able to take care of yourself. And this is absolutely a big factor that we need to consider. When I look at eco-maps around the country, we see people who only have service providers and no friends, no family in their circle of support. The lack of social connection, the promotion of social isolation of people with intellectual disabilities completely undermines their well-being. Their exclusion from churches and synagogues, et cetera, et cetera. The fact that people with intellectual and developmental disabilities do not have opportunities for diet and exercise also undermines their well-being. So you can see that if all we're talking about is managing challenging behavior and not really having an integrated wellness-based approach, we will never move forward in building the capacity that I spoke of earlier. We will never be able to really help include people with intellectual and developmental disabilities with mental health needs in the community. So all of our model really tries to incorporate within the fabric of everything that we do all of these concepts rather than just trying to treat an illness. We're trying to promote wellness and well-being. And here are the START approaches, and I'm not going to go into it in detail. This is a diagram that really shows you what these approaches are, and really there'll be a lot of training on this going forward, but what you need to see is that a lot of what I spoke of earlier is incorporated into this, especially positive psychology, which I'll talk about later. What we see is that all of this has to be incorporated. And in doing crisis work, this is one of my, I think I said this 200 years ago when I first started doing this work, and I realized that a crisis is a problem without the tools to address it. And I can tell you why. I was a mental health clinician when I got into this field, and half the things that I saw when people asked for help on the IDD side would not have been tolerated at all on the MH side. So, on the mental health side, if somebody says boo, you're like, oh my God, they were verbally aggressive, blah, blah, blah. It was like a big crisis, and you had to go get screened and medicated and all this stuff. On the IDD side, people would come in and say, he broke 17 windows over the last 3 months. I got sick of replacing the windows. We're in crisis. So you see, it's a matter of perspective. It's an absolute matter of perspective. And I also saw, being a member, I was on a mobile crisis team for 11 years. People would say they're in crisis because they didn't have staff in their house. So defining it is very different, and perhaps they were in crisis, but it really wasn't what we were defining. So I'll give you an example of a problem without the tools to address it. And my husband's had this problem with me for many years, and it's never going to get better. And it has to do with changing tires. I am 62 years old, and hopefully this tape will be on for the next 3 years, so I'll remain 62 years old for the next 3 years, which is really good for me. My youth will be maintained. And one of the things that my husband has been trying to teach me for the past 35 years is how to change a tire. And so he'll show me where the tools are. I believe there's something called a jack and a spare and a wheel and other things. And he'll stand over me and give me the instructions and the tools. And I can tell you right now that if I was in some sort of on a desert road with no phone and no AAA, I would be in enormous crisis. because although I have the tools to address it, I do not have the knowledge on how to use the tools. So I used to say that a crisis was a problem without the tools to address it. And now I have learned over time that it's not just the tools, it's the knowledge of how to use the tools. It's actually the willingness to use the tools. So remember in that early slide I said, you have to be open to learning? I'm not open to learning about how to change a tire. I am not open to it. Maybe my husband, Keith, can watch this. I am not open to it. And as a result, I will never change a tire. Some of the systems that we work with are not open to learning certain things, or it is our approach on how we're teaching them those things that don't allow for them to be open. So we have what we call a tertiary care crisis intervention perspective, where we really look at what is the capacity. So with regard to flat tires, my capacity is to have those tires that blow up and change themselves. That's my capacity. It's not really good at changing tires. Or AAA, or knowing how to ask for help. That's the best I'm going to do. I'm never going to be secondary specialist. That would be calling my husband to help me. And in a tertiary intervention, it would be calling a tow truck to tow me. So you can see that you need all three levels of intervention, because it's not only the tools, but actually the knowledge and ability to use those tools. So the tool really require discovering the strengths in all of us, and also acknowledging that what puts me in flow doesn't necessarily put others in flow. So my husband, as an example, is an engineer. So he's very good at engineering related things. I'm not even good at describing what the heck engineering related things are, but I'm aware that he can change tires, for example. I am really good at talking about your feelings about that. All right, I go astray. So what we're looking for are the tools to promote well-being, and really it's not about a pill or a plan, it's about the person and their strength of character. It is not about a pill or a plan, it's about a person and their strength of character. That's one sentence that I really want you to remember going forward if you're going to develop a START team. We don't reduce people to a plan or a magic medication. It's really about looking at the person, their humanity, their strength of character. That is the biggest tool that we have. That is the tool that we can engage with in order to prevent the crisis from exacerbating. So the START approaches include a strength-based model, which builds practices on positive psychology, which is incorporated into everything that we do. And the premise is in positive psychology is that all people have inherent strengths and skills that promote resiliency and resourcefulness in the face of challenges. We also, which we haven't talked much about yet, but will moving forward and in future trainings, we also really incorporate cultural and linguistic competency, and that is really important because everybody has a cultural and linguistic identity, and to ignore it is to ignore the core humanity within all of us. We all come from somewhere, we're all part of something, we all bring that forward, and we all should value that in each other. And that is true of both the people we work with and the people we work with to support the people we work with. And we also promote leadership and dialogue using systemic consultation. So we address solutions to problems within the context of the system. We really think about where does the person reside, what is their ecology. Some of you may be familiar with this from a social work perspective, that we believe that all issues and solutions come from where the person resides rather than just the person alone. So there is no problem, illness, or issue that can be addressed by just looking at the person and trying to fix the person. It's really about engaging with the system and having an understanding of what the system's needs are. And also, we, again, incorporate a biopsychosocial perspective, and we have a crisis prevention and intervention planning process and response that incorporates all of these things that were just mentioned. And here is our 3 A's. Just to remind you what the 3 A's are: access, appropriateness, and accountability. Here's access. Unfortunately, what you have is what we call no insurance. That's going to undermine your access. Appropriateness. Timmy is asking Lassie for help. Lassie goes and gets psychotherapy. The help doesn't match what Timmy needs. I know you're chuckling out there. And here's my favorite one. You go to a team meeting. Picture this as a team meeting. Somebody's testifying in court, and the one jurist is looking at the other and saying, I don't listen to the evidence, I like to make up my own mind. How many of us go into meetings and we don't really listen to the family, or we don't really listen to the service recipient, or we don't really listen to the occupational therapist or the teacher because we know all the answers, and we're just waiting for our turn to speak? That is an opportunity lost. That is a benefit of collaboration that is undermined. And the most important thing we need to do is listen. So there are elements of cultural and linguistic competency that are incorporated in all levels of START services, and here's a portrayal of it. And again, I'm not going to go through each slide in detail, but rather to say this is the way we look at things, that being very understanding of how cultural knowledge and skills is key to what we're doing, and that we need to review behavior, presentation, and the ability to take care of oneself and to flourish in the context of your culture and your values is extremely important, and to understand that there's a great deal of diversity in our society which should be nurtured and supported because it creates all kinds of understandings and opportunities that would otherwise be missed if we don't embrace them. So we are an evidence-informed practice, and that means that we take in information, we process it, we act on it, we test what we're learning, we take in more information, et cetera, and it's this cyclical effect. So you will see that all START programs enter data into a database every single day, and that data is reviewed on a regular basis. It is not just there to collect dust, although, virtual dust. It is there to inform us about whether our practices are working, whether teams are doing what is expected with regard to fidelity of the model, but most important, to inform us about whether or not the systems and individuals that we mean to support are actually benefiting from our efforts, and whether changes need to be made as a result. And we all have to work together, and being the groovy hippie that I am, I'm here to talk about synergy. And synergy is a dynamic state in which combined action is favored over individual component actions, because when you combine them, what it creates is growth in all elements. And so if you combine things, you will actually grow the opportunity and capacity for all members of that combined force. And here's a demonstration of synergy. So you'll see in this demonstration that we have two separate triangles, and when we move the arms of the triangles together, we end up with 3 triangles, and we end up with more additional resources through synergy. So Maya Angelou said something very important, and it's kind of the mantra that I think we all have at START as part of the model. And she said, do the best you can until you know better, and then when you know better, do better. So all of this is really about being a community of practice, which really encourages people to learn and to grow and to do better as a result of what we're learning, and really to face challenges in that context and be very respectful of that process. There was a recent New York Times study back in February of 2016, which really talked about collective intelligence, which is a pretty important concept, which really speaks to the fact that together, when we give each other the opportunity to share and learn together, we all become much smarter. And Google did this research about what should the makeup of specific teams be, and what what promotes the ability of those teams maximizing their collective intelligence. And what they learned was it wasn't about the degrees people had or the years of experience that they had or anything that was all that tangible with regard to the individuals, but rather, as long as everyone got a chance to talk, the team did well. But if only one person or small group spoke all of the time, the collective intelligence declined. So if I'm sitting here talking, which I am now, trust me, I'm sitting here talking to you, I'm not learning all that much by talking to myself. I'm talking to all of you through this video, but I get much more out of dialoguing and listening to others and then having the opportunity to make a contribution to that dialogue, which is why if you're using this video as part of your introduction to your START coordinator training, you'll be watching this and then gathering together with a group so that you can talk and share about what you're thinking, the questions that you have, what you need to know, what you need to contribute to the discussion, and then everyone will be more intelligent. So we're part of the University of New Hampshire Institute on Disability Center for START Services, and we do a lot to build capacity, lots and lots of training. And I'm just going to go over this list quickly. I'm not going to spend a lot of time on the details of each of these elements, but I just want to share with you all of the offerings of the Center for START Services. We have something called professional learning communities, which help to both link systems, create community capacity, and also to build communities of practice and learning. We have a professional practice group improvement groups. For example, we have a physicians group for medical directors that meet regularly and get CMEs through Dartmouth Medical School. We provide coaching, technical support. We have office hours. We do have a certification program for coordinators and for your START program. There's something called the National Online Training Series, which we're very proud of, which goes through about 9 or 10 months a year. We have special trainings as well through that series, all of which is meant to share with the network, share capacity. There's a course to prepare people for certification. There are fidelity guidelines to prepare programs for certification. We have lots of curricula and training throughout the lifespan. We have clinical education team meetings, which I spoke a little bit about earlier, which are forums that are very case specific. They're de-identified so that the community, the local community, can learn about a particular issue today. We talked about fetal alcohol spectrum disorder and executive functioning. It was a very interesting dialogue and discussion, very helpful to all of us, and I learned a lot personally from the discussion. And we also have the START National Training Institute, which is an annual training institute that occurs in different locations throughout the U.S. Here is the START model. This is the model, the program model that portrays a full START program. Not all states and locations have full START programs. We do recommend that you have the entire model, but because of resources and lack of opportunity, that is not always possible. And we don't want to undermine any system's ability to move forward in any way that they can. So we do offer different options for becoming a START certified program. A lot of what we will be sharing with all of you moving forward is START practices. We have a network, which is a group of individuals with a common repertoire of knowledge about the way of addressing similar and often shared problems and purposes. So through our communication with each other, we become less isolated as professionals, and we increase the ability for the people we support to be less isolated in their local communities. We have a collective practice, and it's made accessible through all the training opportunities that I talked about earlier. I have to say that one of the things that I've learned is through this collective practice process, we have really become much more effective in a shorter amount of time than just starting from the beginning and figuring it out on your own. None of what we do is all that fancy, but what we do is really based on learning about what is best practice, and through that learning process, efficiencies have developed which allow us to help new states and new regions to get there faster than we did in the early days of START, and I think that's very important to know. What you should also know is that we really consider what we do and how we train as an apprenticeship. You learn by doing the work. We don't really think that you can take a course in this and study it and be passive. It's really sort of rolling your sleeves up and getting right in there. In a way, it's an art form. Each one of us creates our own work of art in the way we approach this, but the methods that we use are taught, and the expectations help to promote that ability to really thrive in that apprenticeship. We have many, many different kinds of assessments that we use. And again, we certify coordinators. We have access to national and international experts in the field. If you know somebody who's really smart, it's likely that the Center for START Services will steal them. We're very good at stealing people. We are a national team. We have people from all over the country who are stolen, and you know who you are. And we intend to steal you. If you're brilliant, we want you. We have multimodal consult teams that we are associated with to integrate a better understanding of people with more complex needs. And again, we have clinical education team meetings. We have something called the START plan, which evaluates the needs of the individual and their system, crisis plans, service evaluations. We have a database. We provide systemic analysis, practice groups, et cetera. Our therapeutic services include in-home therapeutic supports and coaching so that individuals get their caregivers get coaching in the home with the person and the caregiver rather than taking them out, especially children. We find it very traumatizing to place children outside of their family home. It's much better to kind of work with the family on their success in the home. We do have centers, which are, we call them resource centers, which are therapeutic communities where we incorporate all of the practices we talked about: cultural linguistic competency, strength-based practices, rigorous approaches to biopsychosocial assessment, positive psychology, nutrition and exercise, all of these things and other things that I failed to mention that you'll learn about are incorporated into our practices at the resource centers. So, let's talk a little bit about START coordinators. They are the most important mechanism. Well, to refer to a human as a mechanism is absurd, but they, if you were to think of this as a well-oiled machine, and now I'm getting into territory where I have no idea of what I'm talking about, but something that works really, really well. The thing that keeps it all together and working well is the START coordinator. So we invest as a system, as a community, in really supporting the START coordinator to be prepared to work in complex and uncertain contexts that demand their own autonomy, their judgment, and ability to solve problems in action on the spot. And that requires a great deal of rigor and training and creative thinking. So you really need to have innovation, creative thinking, and a skill set that really is critical in order to be successful as a START coordinator. Although we do think that social workers and licensed mental health counselors are the foundation training, graduate training for these positions, psychologists also do well in this work, and most of it does come from us all learning together in the learning groups that we provide here at the Center for START Services. We also focus on innovation, and innovation is defined as something that can't be standardized. So even though we have all these standard practices, we are innovative within the context of those practices. The people who innovate are not simply doing whatever they want, and innovation does not happen in a vacuum. This is where the team approach comes in. So you have to be creative and innovative, but you also have to understand the standard practices. Innovation and creativity occur in the context of this community of practice that we have created, and the START network is part of that community of practice. So to explain it a little clearer, it's like we're a big village of MHIDD people, providers, lovers, friends, communities. And what we're all trying to do is learn together about how to promote how every single one of us in our community can flourish. And that takes all the creativity, knowledge, innovation that we've been describing, but really the coming together as a community and sharing in what we're learning is an essential part of that process. So the START coordinator really promotes the community of practice, and through the values that we share, the skills, affiliations, habits, understandings, and we really try to give STAR coordinators a lens in which to view people and systems through our training and apprenticeship process. And the STAR coordinator practices establish a community with a shared culture or ideology, a way of seeing things, valuing, and practicing our craft. So you can see how important the STAR coordinator is. We work with many other disciplines in our practice, but the STAR coordinator holds the keys to bridging the gaps, to bringing people together, and to facilitating the change and engaging in this practice. So STAR coordinators are encouraged to make the link between knowing and doing through the practice, and to have some sort of reflective processing. And we have lots of methods in which that can happen, including groups that we have, teachings that we provide, coaching, office hours, etc. We also provide didactic information you need. So people ask, why do we provide all this didactic information? Is it to make sure that STAR coordinators know all the answers? No. No. It's to make sure that STAR coordinators know the questions that they should ask. So any base of knowledge is just information for today. And the only way that we can learn and improve upon our practices is to know what questions to ask, to be curious. So the base of knowledge that we provide and understanding is meant to really think with people, to maybe ask questions about things that they wouldn't have ordinarily questioned without us. But it's not to be the know-it-all, to the do-it-all, the think-it-all. It's really to facilitate that dialogue and promote that community of practice. So what are we trying to do? We're trying to promote exemplary leadership skills. And here is some really great stuff from Kuzi and Posner on leadership. And I use these phrases all the time. And I'm not going to go into it again in great detail, because this would be a 17-hour presentation and you'd keep it running while you're on your computer. And I'm not doing that. I want you to listen. And so here are some of the elements of good leadership. And I think I say model the way. I'm looking at Beth probably like 64 times a day. So the idea is, if you don't walk the walk and you just talk the talk, you're kind of full of it, you know? And I didn't say you're full of you know what, because I'm trying to clean this up, because I'm at the University of New Hampshire. But you're full of it, really. The tools and methods that we have are no good unless you use them and you model the way toward positive change. You model the way toward forgiveness. You model the way toward noticing all the good things in people. So one of the things that I have learned in terms of modeling the way is you never go into a system and judge them in a way that will completely shut down your communication by deciding you're superior and they're inferior, or there's something wrong with them, or the people that, there's something wrong with the family, there's something wrong with the person, there's something wrong with the system, but rather you model the way to being open to what's right about everybody and how we're going to engage in that and move things forward and create positive change. You need to inspire a shared vision. So if we're only following my vision and not encouraging others to be part of seeing things, so another way of looking at shared vision is establishing a common understanding so that we can all move forward together. You have to challenge the process through inquiry and active listening. So we do not challenge the process by telling people they're wrong. We challenge the process through asking questions. We challenge the process through listening to what people have to say and finding those nuggets that can help move them forward. We challenge the process through reframing and reimagining with stakeholders to free them up to see that there is a solution to every problem. A crisis is only a problem without the tools to address it, and we need to find those tools to move forward. We also have to enable others to act. We work toward building capacity on all levels. We do not ever want to be the geniuses that have to come in and save the day. In fact, you'll see in most of our studies, when we ask families about their experiences, we don't ask them about how they're doing with START. We ask them about how they're doing in life and with the mental health system and with their child. Because really, we're trying to get everybody else to do what they want to do, and we're trying to support them in getting there. And finally, and this is the one that is sometimes ignored, and we really have to do much more of it for the systems that we work with, and also reflect more of this on the people that they work with, which is encouraging the heart, recognizing contributions, celebrating successes, creative ideas, etc. There's a method in positive psychology called strength spotting, which you can hear about in the positive psychology training, which really points to noticing, spotting strengths in people, positive things that have happened that they might not even notice themselves, to give them the opportunity to feel good about themselves and recognize their own contributions. And we try to do a lot of that on our national team with each other. We do that all the time, as much as we can, but we need to do more of it, I think, especially because people come to START because there's a problem. We tend to be problem focused. And honestly, of course, we have to give oxygen to the system. Remember that slide in the very beginning? You can't give oxygen to the system by saying, oh, Johnny hit you with the chair, but he's got a great little sense of humor. That would not really be an appropriate strength spotting opportunity. So you really have to get rid of the chair and calm everybody down, have a little empathy for the fact that Johnny hit somebody with a chair. But your goal is always to encourage the heart. It's always to get back to, well, how is Johnny usually? And what are some of the great things that you noticed about him? And how can we get him back to that? So very important. A very, very, very big part of what we do is that we are evidence informed. START was developed, as I said earlier, in 1988, and we had a database in DOS. I don't know if people are familiar with DOS, but you had to actually put in the codes. You had to make codes in order to enter data. We also had something called telephone booths. I don't know if you're familiar with those, but they are these little areas where you get on a phone and, oh, by the way, on the phone you press these little things and you hold on to this thing. And by the way, it's not accessible unless you have a quarter or a dime or something like that to pay the little phone. And then the phone runs out of money in the middle of the crisis, and you have to find more quarters. It's a lot of fun. And the reason why you know to call is you have something called a beeper. And yes, START coordinators and drug dealers had beepers back in the 80s. And we used those tools a lot. And what we did was we entered data. And from that data, we were informed about what works and what doesn't work. And so we have been collecting data for 30 years, and all of our practices are based on data analysis and research. And I'm going to share some of that moving forward, but I just want you to know that we don't just collect the data to store it and say we have it. We actually use it to inform our practices. Albert Einstein once said that he's not saying it anymore, he passed away. This is a little funny little interlude. If I had an hour to solve a problem, I would spend 55 minutes thinking about the problem and 5 minutes thinking about the solution. We spend way too much time jumping into that solution without knowing what it is we're solving, and that results in failed attempts at problem solving. So we really believe in reflective inquiry and assessment, and we do a lot to kind of evaluate what's going on with the person and then evaluate what we did to make sure that it helped the way we thought it would. And we use positive psychology, as I said earlier. We always start with positive thinking. You really have a choice about how you view something. We're being challenged by that in the current political climate, and I'm not going to tell you about that right now. You'll have to make up your own mind. But sometimes that's more challenging than others. But we can change how we as a group think and feel about what we see. And you can cultivate sustainable positive feelings about ourselves and about the people around you through this positive thinking, and create and inspire that in others through this approach. And so all of our meetings are really dedicated to that, like making the choice to really see things differently, cultivating feel positive interactions, and inspiring others to do that as well. We use a positive psychology approach, and I think this is like probably, somebody said that we have a secret sauce. I don't know what that means exactly. I think it's a Burger King or something illustration. Being a vegetarian, I'm not familiar with the secret sauce, but if we had some sort of a secret to our success, I would say one of the biggest secrets is positive psychology, which is not such a secret anymore. And Duckworth, Steen, and Seligman said in 2005, we believe that persons who carry even the weightiest psychological burdens care much more in their lives than just the relief of suffering. Troubled persons want more satisfaction, contentment, and joy, not just less sadness and worry. And I think that is absolutely key. And that's also true of the people who support the individuals referred to us, that if there's joy in the work, joy in the engagement, positive experiences for everyone, everyone will flourish, everyone will be in flow, and everyone will benefit from the experience. So positive psychology is a shift in perception where we reframe and we refocus. There's really more than one way to view a situation. And one of the things that Dan Tomasulo reminds us of when he talks about this is that optimism can be taught. I don't think Winnie the Pooh ever did anything to help Eeyore with this. Perhaps he would be happier had he been taught how to be a little more optimistic. We all have Eeyores in our life that we try to tickle and make feel better. And you can see that if you give them a different approach to looking at things, that they can actually be more hopeful than when they first started out in your engagement about a problem. If you practice these skills, you'll be more effective in all elements of your life. We have had directors of START programs say, not only has it improved the work that I do with people, but it's improved the work that I do on myself. This practice, positive psychology, is really very impactful on everyone who you're connected with. When we do gratitude exercises, people actually share these outside of the village we call START, and we extend that ability of gratitude to everyone. And I know for those of you who are being trained by START, you will see demonstrations of things like gratitude moving forward. It's very, very powerful to experience gratitude, to notice beauty and excellence, to really have these connections with each other that are very strength-based. It really helps to engage and be successful. START also provides 24-hour community-based crisis services. So it's START coordination. Our approaches include assessment, data collection, and positive psychology. And now we're turning to the tertiary part of the model, which is crisis evaluation, prevention, intervention, stabilization. We do have a 24-hour mobile crisis team. We do insist that people actually show up when somebody is having a problem rather than chat about it, because there are no witch doctors or we haven't found a way to really help people, give them oxygen from afar. We have when we have people admitted to the START centers, discharge planning meetings, and all kinds of evaluations and dialogue occur so that the person's natural support system, paid support system, remain connected to the person even when interventions are necessary. So we're going to talk a little bit about the research, the most recent research on the START model, and some research from the past. We are very evidence-informed. So our earliest findings were in the year 2000. It was a 4-year longitudinal study. And then in 2007 was the next study where we did a comparative analysis on the START model. So in the first study, you'll see that we learned that when you compared year 4 to year 1, the trends in all kinds of crisis services declined over time, and it was significantly different. So, for example, in the first year of the 89 people, 30 of the 89 were hospitalized. By year 4, 19 were hospitalized. In year 1, there was 42 crisis contacts. In year 4, there were 14 crisis contacts, et cetera. We did not see a statistically significant change between subsequent years 2 and 3 and year 1 in this longitudinal model until we got to year 4. So we learned from this process that systems change takes about 4 years. But what we didn't really account for in 2000 was we were making it up as we went along. Remember, the model started in 1988. This was actually my study for my doctoral dissertation. We didn't really have manuals and forms and that kind of thing. We sat around and used our collective intelligence and our strength-based approaches and rigorous approaches through our work with Robert Sovner, Bill Gardner, and others, but we really didn't have a fidelity practice. So this was the outcomes associated with that. And here are the emergency respite rates, again, a significant drop in subsequent years. So then we looked at, in 2007, the next program to be developed after the Massachusetts START program was the one in Tennessee, 10 START. And you can see that they did a comparative analysis between 2 small groups of 15 individuals each 30 individuals each, where they looked at costs associated with the START model. And you can see from this that one of the things that we learned from this little study was it costs about 3 or 4 times more to support somebody with similar needs without the START model than with the START model. And so we were very happy to see that, and there were very significant positive outcomes as well. In recent years, we developed the SIRS database, and we've become much more sophisticated about the way we collect and report data. So the purpose of the database is to collect and report on various data to provide evidence-informed information to stakeholders and community members, and we at CSS to learn about what practices work. And so we provide service outcome feedback to project managers. We capture de-identified information about START clients nationally, and we support a continuous quality improvement approach through the data collection and reporting. We have lots of new projects in START. Again, I'm not going to go through them, but we're constantly adding. Oklahoma just joined us. Actually, Maryland is the newest state, but they're not on the list here yet because the slide was made prior to Maryland joining us. There are several other states involved. We have lots to celebrate in terms of the newest START projects. So here's the SIRS database, and here's the next study that was conducted, and this was a more recent study in 2016, I believe, 2016, following much more data in the START database. And the first thing we wanted to do was look at psychiatric hospitalization amongst individuals who referred to START. The number of people, remember the first data set was 89 people, the second one was 30. We're now up to 3,299 people that we followed over, that we gathered data over 4 years. And here's some of what we saw. Again, 80% of referrals listed aggression as the primary need. And we learned a little bit about the population so that we would be better informed moving forward. The results were that 28% of referrals had been hospitalized in the past year prior to hospitalization. That is very high rate of inpatient use. We saw that there were factors that increased hospitalization. Being African American increased the likelihood, and male increased the likelihood that you would be hospitalized, and certainly having a diagnosis of psychotic disorder and a high irritability and lethargy score in your ABC also increased the opportunity for hospitalization. So the conclusions from this study were that high levels of psychiatric hospitalization exist amongst people who refer to START, and that's a target for us to reduce the need for hospitalization. That targets for intervention and supports are there. We really look for that the young adults are more likely to have difficulty than the older adults in our system, and there are socio-demographic disparities. Race is one of them, whether or not they're on SSDI, and also their level of ID seems to affect their access to mental health care. So fast forward to a more recent study was on improvements in mental health outcomes and caregiver service experiences. And this is an article published in AJIDD, the American Journal of Intellectual and Developmental Disabilities. It is currently in print. It should be out shortly. And what we were looking at was improved patient outcomes through the START model. And our study goal was to do a 1-year pre and post and to look at caregiver service experiences. So we had 116 families that were interviewed, and we measured the caregiver perspectives about the effectiveness of their mental health system prior to coming to START, and then 1 year after we linked them through START. Questions are not about START, but rather the system as a whole, and they reflect the measures of effective services. And you can see from this slide that there was a significant improvement in how families gained access and support from the mental health system 1 year after START began working with them. They also did much better in terms of their ABC scores, their measures of behavioral challenges and mental health conditions. There was great improvement, statistically significant in all areas measured as well. And we also looked at emergency service use, which also dropped dramatically after involvement of START. So when you had a mobile crisis team involved and somebody to help divert you from hospitalization, there was a great drop in results. There was also all of these changes in the ABC were significant. Now, what was really important was this was a 1-year pre and post. Remember I said from the first study, we thought it takes 3 to 4 years. With the fidelity to the model and with the methods being much more concrete, we were able to see the ability to train people and get them to become engaged in the community of practice, improved outcomes dramatically with regard to the effectiveness. So our conclusion was that there were improvements in all study goals. This was very exciting, where I didn't expect this to happen, and when the data was analyzed, I got a call on Christmas Day wishing me a Merry Christmas, because there was improvements in all 3 outcomes at the level of service user, caregiver, and system. There's not much published on this, and it's a great publication to have it out there to talk about how you can be solutions focused and have a quick remedy that really helps people if you follow a plan. And there's very little evidence for any population on the effectiveness of crisis intervention programs. So this really adds to the literature. And of course, the family experiences implications are wonderful to see that caregivers really feel better. I'm sure there's a relationship between the caregiver feeling like they have the support they need and the person ending up in the emergency room. As we talked about, primary capacity being our goal, it feels like that was happening. It was happening. But we really assumed that this had to do with families, that because we worked with families and families do very well in collaborating with START and the families remain consistent, that this really spoke specifically to family caregivers, and there's no way if we work with residential programs and have these measures that it would work. So here are the implications again. There was a 40% reduction in ED visits, this is all like very, very exciting. But again, it was very specific with families. We do believe that directed, targeted crisis plans, crisis response and consultation services play a key role. The influence of these interventions can be seen in the analysis from the FEIS, where families said they didn't know who to call for help. In the pre and then in the post, they did know how to call and they got the help they needed. These findings, alongside a reduction of inpatient admissions and ED visits, are promising in terms of supporting those with the greatest needs. So we had this next study, which really freaked me out. We got this Hope Foundation grant, and I said, oh, no, this isn't going to work. This is residential programs. We will not have measures of success. And this is the Iowa START study funded by the Hope Foundation, as I said earlier, and this is published in JMHRID, and it's actually been published. So the objectives of this study were to examine changes in mental health systems, rates for emergency psychiatric service use in a sample of individuals with IDD served by a Midwest START team. And you know how it is, you people in the Midwest, we expected differences. Well, the other study was Texas and New York. So, but very urban settings. This was really a more rural setting, and the participants were enrolled, again, about a year, on average 430 days, and we weren't sure what was going to happen. So the total N was 41. It's a small team. The distribution of the population looked very similar to the other distributions that we looked at, so there was no distinct differences except for the fact that 95% of the people were white. This location in Iowa is not one that has a lot of racial diversity, so that was expected. At the time of enrollment, most of the sample lived in, supportive community settings. You know how those people don't listen. Only 7% lived with their families, and 7% lived independently. Some were in jail at the time, and others were in other living situations. So here are the scores, pre-test, post-test on the ABC, and we had similar improvement where people, their emotional stability and their challenges significantly improved in the time when the system was engaged with Iowa START. And we also saw a significant improvement in hospitalizations. There were 53% of this group, 53% had been hospitalized by the day of referral to START, and it was down to 24% in 1 year, which is a highly significant improvement. Psychiatric emergency department visits, 66% had one or more psychiatric emergency room visits, so they spent time in the ER, and that was reduced to 39% after only 1 year. That's a highly significant improvement. So the implication of these data is that START can help to improve outcomes for individuals who are at high risk of emergency service use. We saw improvements in the hyperactivity, lethargy, and irritability scores on the ABC, as we saw in prior studies. And we also saw a 50% reduction in urgent and acute service use. Very significant. The study followed individuals prospectively, while prior investigations conducted a retrospective data review. So we started following them from the first day, whereas in the other analysis, we had the data and looked back. So that was a slightly different, more powerful analysis. The positive changes observed in this study mirror those found in previous research. So we learned that in residential provider services, we also can have an impact to help people do better in their life and reduce the use of emergency services. So the next study that we're looking at is the family caregiver experiences at time of intake. The number of surveys was 564, and one of the things that we see is that There are significant differences between mothers and fathers' experiences. We have virtually ignored the fathers, and the fathers are saying they're not getting enough support. We're learning this through our study and analysis. This is very important because it will impact our practices. We will pay more attention to fathers. The chronic health conditions also contributed to poor experiences in caregiving. So again, we really want to talk about how health and mental health are integrated and to promote well-being, and also are contributors. The undermining of health undermines mental health. If you're not feeling well, you're not going to be emotionally healthy. If you're emotionally not doing well, you might not take care of your health properly. The two work together hand in hand and need to be addressed as such. And one of the things that was most significant in these very distressed families, where remember, the people who are referred to START are never referred to START because things are going well. When we asked them what they wanted, less than 1% of all the people interviewed, 564 family caregivers, 1% requested out-of-home placement, less than 1%. So this assumption that what families want to do is dump their problems, dump their kids, dump their young adults, not take care of them, not have them in their family, is absolutely false. What families want is an opportunity for their children to have an enriched life. The next study, and there's just a few more, I hope this is interesting to you. I think this is extremely important work, is the dementia detection study, which just began in March of 2018. And as you can see, we had some funding from Johns Hopkins to pilot this study. The thing that I found most upsetting about it is that they established that being elderly was ages 50 and up. Are they kidding me? 50? Seriously. So ages 50 and up will be screened. Dr. Barnhill wants this study to be completed before he needs a dementia screening. So that's sort of the levity in which we're dealing with the fact that 50 and up is old, because some of our leadership is elderly. But we're going to see how, the thing that we want to look at is whether or not the diagnosis of dementia has been overlooked in this population referred to START. And that is important because it affects treatment and understanding of their presentation. So it's a very important study. We have an established research committee, we have research partnerships, and it's probably one of the most exciting parts of what we do is our emphasis on research, analysis, data, so that we can contribute to the larger understanding, the larger network of community providers to share this wealth of knowledge that come from the SIRS database and the START network. There are more than 7,000 people in the START network right now in terms of service recipients. It's probably one of the largest, if not the largest, database of its kind. And we want to make sure that we learn from the data, we learn from what we do, we learn from the people that we're entering this data about, so that we can improve our practices. And here are the universities involved: Johns Hopkins, Georgetown. And we really are very excited to have these partnerships. Boston University is another partner, and we hope that this will really flourish moving forward. And the START programs, any START program in the country can be involved in research. We have lots of methods to engage with people, and there are new projects all the time with regard to research. So in conclusion, in describing what we do with START, I know you didn't learn about any of the actual practices, but the basic overview of what our community is trying to build. And I hope this overview kind of gives you a glimpse of our values, our model, and our approaches. But really, it's about systems change, and systems change has its ups and downs. And another quote from my old friend, the late, great Albert Einstein, is you never fail until you stop trying. So we as a community continue to strive toward doing great things, but we realize that we will hit obstacles along the way. But as long as we continue in these efforts, we feel that success is imminent, and we are very happy to be part of your community and we hope that you will become part of ours, and we look forward to further dialogue moving ahead.